You can do this maybe.
I have Phil Alexa Coast from Manchester.
Working with them. Right by Carrie. And there's Lawrence.
Slide on over. Slide on over, yes. Before we start, I'm Wendel from Cambridge, and thank you all for all the extensive email conversations you've been in with me, and planning of this gathering, which was awesome. And Carrie will do the official intro.
Good morning, everybody. Can you hear me? Do I have to use the microphone? Yeah. What? I am Carrie Carroll, and I am representing the RWJF Culture of Health program largely. So I'm here to say hello and to thank you all for being here from the Robert Wood Johnson Foundation, as well as from the University of Wisconsin Population Health Institute, and we collaborate together on the RWJF Culture of Health Prize program. I really want to thank Yose and Claude and the Cambridge team for so much work that they put into getting, thank you. Yes. No small endeavor to get any group of people together, and it takes a lot of work. And I know Wendy and Dave from Fall River last year also experienced that, and I just think it's a wonderful, I don't know if it's going to be an annual convening, but it's a wonderful way to support you in your networking with other prize-winning communities from the Northeast. So we're super happy that you're here. I did want to check in, because the years are kind of going by a little bit since the prize, what we affectionately call the prize, was launched. And so some of you maybe participated in the competition and the application process several years ago now. And then some of you, I know, are newer to all of this, and maybe don't even know what any of this is about, or what the prize alumni network is about. So maybe it's a show of hands of how many were actually involved with the application process when their community was chosen to win the award. So, okay, so what is that, about half, a third? And then how many of you are still trying to figure out what the RWJF Culture Health Prize is? Okay, all right. I noticed a lot of hands from, I guess what I affectionately call the emergency response folks, and some of our first responders and police, and we're just so happy that you too are seeing yourselves in building a culture of health. You are a big part of your prize applications, no doubt, in your communities, and I think it's really appropriate that you're here today, especially on this topic of addressing mental health, substance use and abuse, and the opioid crisis. So I'm not going to talk at you for very long, and in fact, I want to ask you all to do a kind of a roll call by community. We don't have time; it's not a big group, but we don't have time to really go around and have everybody introduce themselves. But so I'm just going to go in alpha order of the Northeast prize winners. So I would like Bridgeport team to stand up. I know we have, yes, okay, hello, Bridgeport. All right. And this is so you can connect too. So if you know you want to hear about some lessons learned from Bridgeport, make a note of those faces and go talk to them. I know the Bronx team is here. Morning, Bronx. You're the farthest distance, right? Yeah, thank you. Thank you. I know Cambridge is here. Everett is really here. Thank you, Everett. That's the President's Award. It's not like we're in a competition. Thank you. Fall River, Wendy. Not counting, but Lawrence is here. And Manchester, our newest. those of you that are new to this, you are part of a national network. And if you don't know that, pull us aside and find out more about it. But there are actually 27 Culture of Health prize winners at this point. Soon there'll be over 30. And they're across the whole country. Yes, you do have a concentration in the Northeast, and we do like to say, what's going on in the Northeast? Why are they being so successful? But that aside, there are communities all across the country that are part of this network. And you know as well as anybody that a culture of health is a journey, and it's not a destination. And we know that each one of you are on a unique path. And we also know that you have a lot in common with one another. And again, we're just so thrilled that you're here today. I think it's safe to say this is the first time a group of prize winners has convened around a particular issue or topic. And I think it's a great model for how you can leverage one another to continue to learn. And that is absolutely the point of all of this, to share barriers and challenges you're facing in your communities, and hopefully be inspired by other communities that are maybe trying something a little bit differently than you have, or have learned something that you probably don't want to repeat, and you don't want to make that mistake. So I hope that the spirit today is about sharing and lessons learned and best practices and innovation. And then as you think about how you might apply things you've heard today, just want to remind you of there are 6 prize criteria. And if you haven't internalized these yet, definitely go to rwjf.org/prize or countyhealthrankings.org. They both have the 6 prize criteria. But I'll just highlight 3 of them that I think have relevance, especially today. But the first one is certainly, as you're building a culture of health, is be thinking very broadly about the definition of health. And so as you move through the day, what other sectors might you need to be partnering with, and how might you think about those upstream causes of poor health? What are the intersects? How does employment intersect with substance use, or how does community safety impact how people are challenged with mental health issues? Those intersects are really critical to building a culture of health. Another one I would just call out is, how are you thinking about long-term change and putting in place sustainable policies, whether they're administrative policies or legislative policies, but how are you affecting that long range, how are you taking a long range view of what's working in your community? And attached to that, do you have the right people do you have all the people at the table that need to be a part of it? And I would just call out the importance of having the resident voice, in not only to help you identify needs, but also to help you implement solutions. And along with that is that notion of cultivating a deeply held and shared belief in the importance of equal health for all. So those are just 3 of the 6 that we find absolutely paramount in support the importance of health equity. I want to just take 1 more minute to introduce my wonderful colleague, Erica Girardi. I always get her name wrong, sorry. Erica Girardi. Erica works along with me at countyhealthrankings.org, which is a national collaboration with RWJF and very much tied to the Culture of Health Prize. And Erica's a wonderful resource for communities. She's actually coordinating quite a bit with the Lawrence team, but she really has kind of a pulse on what's going on also in the country, and will also be helping us with facilitation today. So super happy that she traveled here from Florida. And I think that's it. That's all I wanted to say. I would like to introduce Claude.
So, yes, unfortunately it's a cloudy day out there, but I can feel the energy in here, so I'm really excited that you all made the trek. I hope you dropped some breadcrumbs so you can find your way back to your respective homes, especially from even the parking lot. So really, Carrie hit all the high notes, and I have the honor today. This is the second meeting. I can't quite say annual because we haven't made that decision just yet, but we did this as an experiment last year in New Haven. We focused on healthy eating, active living. We've since invited one other new partner, new awardees, so our team from Manchester. So welcome, welcome, welcome. And I just want to thank Wendy and David. You wonder where these ideas come from, and I just remember when we met. So 4 years ago, so we're from the inaugural community in Cambridge. We met our team from Fall River, and we had these conversations. And we just carried that thread forward, and little did we imagine that, hey, wouldn't it be neat at some point to have, you know, who knows how far or how long it's going to last. So the idea germinated into what we see here, and we are a test experiment, but believe it or not, the second annual. So just kudos to the planners. Thank you, Carrie. Thank you, RWJ. But in particular, as I look at Jose, she has aged through this planning experience. And she wears it well, but I just want to say thank you, Jose. It's important. So a couple quick things before I introduce our featured speakers for today's sessions. But this gathering is on sharing systems and policy to promote behavioral health and respond to the opioid epidemic. So that's why we're here. We're here to connect the dots. As we hear about the African proverb that it takes a village to raise a child, well, I truly believe that it takes a village to make for a healthy community, to raise a healthy community. And so this is an opportunity to spend some focused time, talk about the things that work, acknowledge the things that don't work, but also at the end of the day to feel re-energized to go back into the trenches. So I'm really hoping, I'm looking forward to hearing about all that comes of this after today. The meeting itself, again, I didn't mention, so I am a health officer. I'm the Chief Public Health Officer at the Cambridge Health Alliance, overseeing the Cambridge Public Health Department in the city of Cambridge, Massachusetts, also known as the People's Republic of Cambridge, the PRC. And I say that because, you know, a lot of what we do, a lot of what I do is just try to connect the dots wherever possible. And so I'm really hoping through this day that you're able to connect some dots with someone around the room. My tag keeps falling off, but I guess I'm on the red team. So just in case you're wondering which dot that connects with. For today, just know that this is an activity that in my spare time I also had the honor of serving as the member of the board for NACHO, and that's the National Association of County and City Health Officials. We are a community of about 2,800 local health departments. It's been an honor serving on the board. Currently this year as the chair. Have a couple more months to go. I had a full head of hair before this whole process. But just know that we have taken this, the experience of the Culture of Health Prize, and we've imported it as part of our plenaries for our conferences. We talk about this within the work and the programming that NACHO offers to support local health departments. And so the sharing of best practices, however we try to do that, to amplify the reach and the messaging, just know that there are other places and other partners out there. So just again, thanks to RWJ. You already heard about Carrie and Erica. Did want to acknowledge at least some other key folks who will be with you throughout the day. So the organizers, again, more thank yous from the Southern community. So Tim Susi from Manchester, who's a colleague, he's my counterpart overseeing the City of Manchester's health department. We've known each other for years. I consider him to be my neighbor to the north because of just the small geography here in the Northeast. But Tim couldn't make it, but I know that he's got a strong representation from the group from Manchester. So acknowledging Tim's contribution on the planning committee. Wendy and David, again, the dynamic duo from Lawrence.
Fall River. Fall River.
Sorry, from Fall River, yes. Why did I say Lawrence? Fall River, that's right. Vilma. No, did you say?
Oh, I was joking saying Florence, Italy.
Okay. You know what? So we have a heckler in the bleachers.
I just thought it was because Vilma and I look so much alike.
No, she's got another joke there. So Vilma Martinez Dominguez and Alicia Miller from Lawrence. Thanks again as part of members of the planning committee. Paul Richter from the Bronx. Is there a reason we say the Bronx? That's how
We don't ask. It's like
we don't ask, that's right.
It's like
Have- Sorry?
It's like the medical.
It's like the medical school. Got it.
Vatican, right?
Oh, you got it. You know, just they're so humble in the Bronx. Kathleen O'Brien from Everett, again, also part of CMHA, Cambridge Health Alliance.
He's here.
All right, yeah, just acknowledging the planners, Louis Reed and Maritza Bond from Bridgeport, Connecticut.
No, they couldn't make it.
They couldn't make it, but we're acknowledging their contributions nonetheless. And Mary Kowalczyk and we know they CPHD. So this afternoon, or today, you will also hear from folks for the breakout session. So Fernando Tirado from the Bronx, Chris Hickey and Chris Stawas. How do we pronounce it? Stawas. Chris Stawas from Manchester, Wendy from Fall River, Kristen Ward from Cambridge, and then Jared Owen from Moore, from Massachusetts Organization for Addiction Recovery. So just so you can recognize the folks that you'll be hearing from more today. So I do have the honor of at least introducing some featured guests that we have with us. It's a small world. Of course, you have to travel all the way to Springfield to connect with colleagues from across the river in Boston. So that river is much wider than people realize between Cambridge and Boston. But all that to say about our keynote speakers for today. Betsy Rosenfeld is a healthcare lawyer by training and serves as the Regional Health Administrator for the U.S. Department of Health and Human Services Office of the Assistant Secretary for Health for Federal Region 1. And this information is also in your packets. In this role, Ms. Rosenfeld functions as a senior executive for OASH and with the responsibility for a broad portfolio of federal public health work in New England, including such issues as health in all policies, health equity, and the opportunities presented by the intersection of public health, clinical medicine, including the emergence of the community health worker profession as an important tool to reduce health disparities. Ms. Rosenfeld leads a public health team that focuses on these issues across the domains of opioid dependence, women's health, reproductive health, infectious disease, tobacco control, community resilience in the 6 states in the 6 New England states. Her approach to public health in New England has been to undertake a strategy which ensures the integration of population health interventions into the mainstream healthcare delivery and reimbursement systems through collaboration with partners, which is part of the reason that we're here, and looking at models which encourage coverage of upstream preventive interventions. And I'm sure that we'll be talking about the importance of upstream interventions, especially in light of yesterday's news. But at the end of the day, it's all about improving workplace, school attendance, strengthening community health outcomes in general. So you'll hear more from Betsy. Catherine Power, also from one of our federal departments, is a regional administrator, Region 1 for the Substance Abuse and Mental Health Services Administration, so SAMHSA, an operating division of the U.S. Department of Health and Human Services. In that role, she represents the administration at the regional level in fulfilling the agency's mission of reducing the impact of mental illness and substance abuse on America's communities. She provides authoritative advice and assistance on behavioral health policies and innovations for use in the delivery and financing of prevention, treatment, and recovery services, develops regional perspectives on SAMHSA initiatives, and is a visible advocate for individuals with mental illness, substance abuse disorders within the federal government and across the region. And again, one of the things that you'll hear as we talk about the value of being in this space is that at each level we're trying to, again, connect the dots. So what's happening with our federal partners, what are the implications with state level partners, and how does that play out in your respective communities on the ground? Last and certainly not least, we have Captain Bersani. Christopher Bersani is a clinical health psychologist and neuropsychologist by training and currently serves as a deputy regional administrator and the national lead for behavioral health for the Office of Regional Operations of HRSA, the Health Resources Services Administration. Prior to taking his current assignment, Captain Bersani worked for 6 years for the Department of Justice, Federal Bureau of Prisons as head of the Health Psychology Department at the Federal Medical Center in Devens, Massachusetts. Captain Bersani also served over 6 years as a commissioned officer in the U.S. Navy, the Medical Services Corps. Past Navy assignments include positions at the National Naval Medical Center in Bethesda, National Hospital in Jacksonville, Florida, and the Naval Ambulatory Care Center in Newport, Rhode Island. He's also served in several special assignments, including Iceland and South Pole, Antarctica. Captain Bersani has received several awards during his active duty service. In 2006, he was named Psychologist of the Year for the U.S. Public Health Service. Other awards include Meritorious Service Medal commendation medals, achievement medals, special act awards, and several unit commendation awards. I do want to just please join me in thanking and welcoming our featured guests for this second Northeast Regional Collaborative meeting, and let's invite Betsy Rosenfeld up to the mic. Please come in.
Okay, can folks hear me? Good morning. I am one of a trio of folks who are here from the federal government. We are your regional federal colleagues covering the New England region, the 6 New England states. Our office is in Boston, but we travel across the region. And we're here to talk today a little bit about the federal government's involvement in substance abuse, mental health, and the opioid epidemic. Obviously, we come to you at a moment of great flux. We are career civil servants. Catherine Power, Chris Bersani, and I are career civil servants. We were here during the prior administration, and we will continue into this administration. Some of us even were here before the Obama administration. So we are career employees and officials of the federal government. So that's just important to say. We are always available. We're right in Boston, and we have counterparts in New York and New Jersey. So for our friends from the Bronx, if you want to connect with our counterparts, we can connect you with them as well. I have 10 minutes to sort of set the table for the federal role in this issue. So let me just start by saying thank you to Claude Jacob and to Jose Wendel for inviting the regional feds to this meeting. We are really grateful to be here with localities. We often deal with states and other partners, but it's really nice to be able to dig in for the day on this issue. Very excited about the breakout sessions, very excited to learn from all of you. It goes without saying that what RWJ and what all of you are undertaking around building a culture of health is more important now than ever. It's more important now even than it was yesterday. Obviously, much of what the three of us are going to talk about today may change based on what happened yesterday, should that legislation that the House passed go through the Senate and become law, just in terms of public health funding, but also in terms of access to care, right? A lot of what we're going to say depends on people having access to care. So if that changes, obviously things are in flux. And just know that we're here and available to talk about that. As a regional office, we are the middleman between what happens in Washington and what happens in states and neighborhoods and communities. So that's the role of the regional office, is to essentially broker what happens in Washington and try to translate it and tailor it to our regions, and also, very importantly, to bring information back up to Washington. So our new secretary announced 2 weeks ago at the annual prescription drug meeting in Atlanta a 5-pillar strategy to address opioids. I know Catherine's going to talk a little bit more about it. It's not that different from the 3-pillar strategy that Secretary Burwell had, and that's good. And there are 5 predictable pillars, but let me just say them out loud, and then we're going to have some material for you to take home. Improving access to treatment and recovery, very important. Promoting the use of overdose-reversing drugs, naloxone. Strengthening the understanding of the epidemic through better public health surveillance. We know that always gives us better data. Providing for cutting-edge research on pain and addiction, and advancing better practices for pain management. All of those are very sensible approaches. The question about how that will all get carried out will be in the funding and in the details of those policies. So, my division at HHS, and again, the 3 of us are from one federal department, the U.S. Department of Health and Human Services, is, as Claude said, the Office of the Assistant Secretary for Health. We are a small staff division. I have a small but mighty public health team in Boston that covers the New England states and focuses on a variety of public health challenges. Essentially, we use a social determinants of health lens to address and achieve health equity. Some might also call it a health in all policies approach. We bring other assets to bear on these public health challenges, whether they're federal assets. Part of what we do is CDC doesn't have a regional presence. There is no CDC in the regions. It's in Atlanta and in Washington. So we help to liaise with CDC as a big kahuna in public health funding. But we also bring philanthropic assets to bear. We bring academic and other public health expertise to bear on problems that get elevated. And our particular office really focuses on gaps. We are particularly attuned to special populations and trying to deal with how something like the opioid epidemic plays out for particular groups of people. So that's what the Office of the Assistant Secretary for Health does. I'm going to quickly summarize, very quickly, 3 pieces of our opioid work that our office in New England has been doing It's not that our headquarters office hasn't been doing these, but these are 3 pieces of work that are unique to New England with respect to opioids that I wanted to highlight for you. And then I'm going to be here all day, so happy to talk some more about this. The first is that we support the state health officers. I don't know if you know it, but your state health officials in all of the 6 New England states and New York and New Jersey meet every month to talk about how to collaborate regionally on opioid work. So to work on some issues that are better addressed at the regional level. Many issues are better addressed at the state level, right? A governor has a particular agenda, the legislature's appropriated some money for opioids. There are particular concerns that are really subject to the state jurisdiction, but there are some issues that are better dealt with regionally, where the region is more powerful as a region. I'll give you a couple of examples. One of them was a special regional surveillance project we undertook with CDC because the state health officers in 2014 told us they wanted better real-time data on non-fatal overdoses. They were getting late data about fatal overdoses, but they weren't able to target interventions to where people were overdosing but surviving. And that's actually where people are partying, where there's drug activity. All of that is very important. It's the tip of the iceberg is the people who die, but the rest of the iceberg was something they really wanted us to pursue with CDC. So that's an example where a regional approach made sense. Another example is state health officers trying to come up with a bulk purchasing approach to buying naloxone, so that you're not just negotiating your discounts state by state, but you're doing it as a region. So every month we meet with the state health officers by phone to talk about what we can do to help them work on their regional approaches to dealing with the opioid epidemic. A second area of focus for us, and we do that with Captain Power at SAMHSA, because those meetings are all of your state health officers and all of your behavioral health, substance abuse leadership on the phone every month talking about a regional approach. We think that's really important to support. The second piece that we're working on, again with SAMHSA and HRSA's help, is the unique ways that the opioid epidemic plays out for women. We know that research shows that there are higher rates of opioid prescriptions for women across the country. I don't know if you know this, but there is swifter acclimation of women's biology to opioids and a much quicker rate of addiction for women. And there's a rising rate of opioid overdose and death for women in New England. So in late 2016, our office, with the support of the rest of HHS and other federal agencies like the VA, convened the New England states. There was a team, a multidisciplinary team from each of the 6 New England states came to this meeting. They were women with lived experience, providers in substance abuse and also in opioid treatment, the state health departments, the state mental health and substance abuse folks, a variety of different players, stakeholders, legislators from each state to talk about what was going well for women, where there were promising practices, and what was going poorly. Coming out of that scientific symposium in November, late October, early November, we have 3 work groups that we're about to launch, and we're excited perhaps to involve all of you or to hear what you're doing in these topics. They are a business case for women-specific treatment, essentially looking at a return on investment for tailoring treatment to women, particularly around their parenting and reproductive years, but not exclusively. Also younger women and older women, where children are not an issue, because of the things I described as being unique to women with respect to opioids. A business case, the intersection of child welfare. The federal government has changed its rules on child welfare recently, and that's really becoming problematic for women to disclose dependence on substance abuses and substance abuse broadly, but also opioids. We don't want the child welfare piece to be a problem when people want treatment and recovery services. And the third work group coming out of this scientific symposium is to look at the role of violence, trauma, and human trafficking for women with respect to opioid dependence and substance use more broadly. And finally, a fourth piece is the role that reproductive health plays. We know that rates of unintended pregnancy go way up when women are discharged either from treatment or from corrections. And we want to make sure, because our office runs the Federal Family Planning Program, yes, that those connections are being made with respect to correctional health. So those are some places that we're going to be working over the next year on women and opioids. And then finally, our office has spent a lot of time on the policy levers around the workforce, the community health worker workforce, as it has emerged over the last decade. It's obviously hundreds of years old internationally and even nationally, but in the last decade in New England, the CHW workforce has become trained, reimbursed, evaluated in ways that it hadn't before, and we're anxious to see whether CHWs can fit into the teams of folks who are working on opioid dependence, alongside and under the leadership of peer recovery, of course. because that is, and Catherine will say more, that is where the real work is. But we think that CHWs may have a role to play because of their knowledge of communities and neighborhoods, and because they come from those places, and they're dealing with substance abuse and mental health anyway. So we're looking over the next year to see where there are some promising programs. I know that the Center for Health Impact in Central Massachusetts just got funded by a small foundation to do some initial training with a group of 20 CHWs around opioid dependence. So there's work headed in that direction, and we want to be supportive of it. I am just giving you a taste of what we're working on in our small piece of HHS. I want to turn this over to Catherine Power, our very wonderful SAMHSA administrator. We're very lucky to live in a region plus the Bronx. She has a counterpart in New York, where Catherine is our SAMHSA administrator. So let me hand you to Catherine.
Thank you, Betsy. I'm delighted to be here with you, and congratulations to all of you for winning these prizes. It really makes a difference, I think, at a local level when an organization like RWJ says you're special. And you can really carry that forward, I think, in a lot of different ways. So congratulations to all of you. I have the pleasure of giving you the 7-minute tour of SAMHSA. Substance Abuse and Mental Health Services Administration, the only agency in the federal government whose name has the conditions that we are supposed to be aware of and serve. We're the second smallest division under HHS. AHRQ is the smallest. SAMHSA has 600 people. I am an office of one. When the Affordable Care Act passed, our secretary said we want SAMHSA in the region. We've never been in the regions before. So we've been in the region for just a little over 5 years under the life of the Affordable Care Act. Why? Well, it's because people with these conditions, that secretary did not want to see those people left out of what was going to happen in the states as the Affordable Care Act came into play and states created their exchanges. She wanted to be sure that this population was not forgotten, and that the public health system would begin to start to talk to the separate and distinct systems that have existed for centuries that states operate for behavioral health, because they never collaborated. So for 400 years, folks, we've had two separate systems in these states. We have a behavioral health system that's staffed by community mental health centers and substance abuse disorder agencies, funded by a separate authority, and you have a public health system. That is over. You're on the cusp of a time when all of that is shifting, not just for what's happening in Congress, as Betsy talked about, but what's happening at your state and local level. The world is changing. The tectonic plates of health are moving, and they have been moving for a while, and they're going to continue to move. Every time a governor changes, every time a mayor changes, every time public health officials change, it's going to keep on moving. And so no matter what the outcome, you are at the right place in time to begin to assure that individuals' behavioral health is paramount. That's our message. Behavioral health conditions are essential to health. Not primary care conditions, behavioral health conditions. So if you care about people's emotional and behavioral health, you care about all of their health. For too long, the world has bifurcated physical health care and behavioral health care. The mind and the body were disconnected. Everything from the neck up was treated differently than everything from the neck down. Those days are over. And you are the leaders to be able to make sure that that gets embedded in all the work that you do every day. Now, what's interesting about New England, and I'll speak a little bit about Region 2 as well, Dennis Romero is my counterpart in New York City, and generally the New England states have high prevalence rates of mental illnesses and substance use disorder, generally, when you compare them across the rest of the country. And I think that that's an interesting dynamic for you to be dealing with, in the sense that we consider ourselves on the track from New York all the way up the coast to Montreal as the states where a lot of trafficking goes on. And so we are in a unique position as a set of states to be able to understand just how prevalent the incidence of mental illnesses and substance use disorders are, And you can get some of that data from what I understand RWJ can offer you. But at SAMHSA, we also have a center called CBISC, the Center for Behavioral Health Quality Statistics, where you can go in and get a profile of your city or your town or your community, and they can give you a behavioral health profile. So it's important data that we pull from a variety of sources that we can give you a picture of what is happening in behavioral health in your community about the incidence and prevalence of mental illnesses and substance use disorders. Now the phenomena is, and I'm sure that's not true in this audience, but the phenomena is that people do not understand how common these conditions are. They do not. 1 in 5 has a mental illness. 1 in 8 has a substance use disorder. Many, and most times, they're co-occurring. So the chances are very good that you yourself, your family members, someone is involved with some sort of mental health problem, emotional disturbance, psychological distress, substance use disorder, addiction, whatever. People do not get that. They do not understand the commonality of these conditions, and, by the way, they don't understand how early they emerge. They emerge at ages 12 through 24. That's a young set of conditions. So we got to get smarter about infant and pediatric mental health. We got to get smarter about youth assessments. We got to get smarter about family interventions and family interactions. We got to get smarter about it, because the prevalence is not going away. It's held steady for centuries, the prevalence and incidence, and by the ages in which these conditions emerge has also held steady. So what's driving SAMHSA? Well, certainly the Affordable Care Act, for the first time in our nation's history, said that one of the essential health benefits needed to be mental health and substance use services. First time in American history. We got to watch what happens with that. So pay attention to what might happen with that. Then in July, we passed the Comprehensive and Addiction Recovery Act, which was a huge legislative win in terms of policy, most of it related to opioids, most of it related to prevention and recovery. In December, we passed the Surgeon General's report. The Surgeon General issued his Facing Addiction in America report. And then in the final days of December of the last administration, we passed the 21st Century Cures Act. Those are your guideposts right now. So those pieces of work are your guideposts for where the federal government sits in our agency, in SAMHSA, across HHS, until that changes. And I think that it's important that when I look at what's going to happen today about your discussions, you're going to talk about mental health first aid, you're going to talk about suicide prevention, you're going to talk about recovery efforts. Those are all things that SAMHSA does. Those are all things that SAMHSA funds. Those are all things that are important relative to the high prevalence and incidence rate of mental illnesses and substance use across the New England states. And oh, by the way, when you talk about suicide, there is a connection across these behavioral health conditions. We're not only having a crisis in opioids, we're having a crisis in suicide. 40,000 people completed suicide last year. 40,000 people. And one of the ways we know is most effective is learning to talk to people about, are they going to hurt themselves? Learning and teaching people how to engage people, to ask them, have you thought about hurting yourself? Because that connection often is the first sign of prevention and the first step in prevention. SAMHSA has a lot of different relationships, mostly, again, as Betsy indicated, with our state counterparts. And so we have relationships across behavioral health and across substance abuse leadership and mental health leadership. We also have relationships with provider organizations, and we have relationships with advocacy organizations, families and individuals in recovery who in fact are having a lived experience of these conditions and are in fact testimony to the fact that you can manage these conditions. That is our principal message of recovery. These conditions, no matter how serious, can be managed, and often self-managed with appropriate supports and care, etc. The three things that SAMHSA does, we fund. Congress doles out money to the agencies, we pass it through us to the state authorities. Those are formula grants that go to your states. We also fund small discretionary grants. That means they are competitive grants. So your organizations, your cities and towns, your agencies can compete for those grants. And they fall into the broad categories of prevention, recovery and recovery support services, and integration. And by the way, that's one of the phenomena of what's happening now, is you're having much more involvement in looking at integrated or coordinated care, so that your primary care and your behavioral health services are co-located. And in fact, we're trying to make sure that people have a much more integrated approach. So SAMHSA does that through its strategic initiatives. And our strategic initiatives basically say we want to pay attention to particular areas. And we want to promote particular areas. So integration is one of those. Prevention is another one of those. Trauma and justice is another one of those. Individuals who have mental illnesses and substance abuse, 99% of those individuals with those conditions have experienced trauma at some point in their life. So being and understanding and creating trauma-informed and trauma-sensitive environments is essential in a healthcare system, essential. The other area of our strategic initiative is workforce development. We're very worried. What are these health systems going to look like in the future? Betsy mentioned the community health workers. That's one aspect of what will be a much different coordinated team approach in delivering health and wellness at the local and community level. But those teams are going to look different than what they looked like 10 years ago. They're going to look different. It's going to be different kinds of individuals with different skills. And we've got to get the primary care folks smart about integrated care and behavioral health care, and we've got to get the behavioral health care folks smart about primary care. And all of that is what we do in our discretionary demonstration program area. What we learn from all that demonstration money, and we only give money for 3 to 5 years, not in perpetuity. We test that evidence-based practice, we package it all together after so many years, and we put it out in the form of evidence-based practices, training, and technical assistance. So those are the things that you need to know about SAMHSA. That we have training and technical assistance and grant opportunities. I've brought along a number of infographic pages that I'm going to pass out for you that really details where we are in terms of SAMHSA's opioid work and all of the resources that are available for that opioid work. And that includes, again, grants, technical assistance, and training. And we think that you have access to those and can use those and put those practices into play. You can have a tremendous, tremendous, tremendous opportunity to influence the overall wellness of your community, as long as you give behavioral health the attention it deserves, not just because of this epidemic. And by the way, folks, this epidemic started in 1995. You know, this didn't happen yesterday or 2 years ago or 4 years ago. 1995, we began to watch the number and amount of prescription drugs that were prescribed with the number of ads that Big Pharma was doing across the medical community. Starting back in 95, the overdoses began to climb. Big Pharma's profits began to climb. What has happened is that has continued on a trajectory, and that the overdose of prescription drugs then, of course, morphed into the use of heroin, morphed into the use of fentanyl, and now is with carfentanil, which is just the toxicity of these drugs is what we have to get at. We have to get at this issue of the toxicity. And then we have to have opportunities, access to services, so people will not, in fact, purchase the deadly stuff on the street, but will, in fact, be given medication-assisted treatment, be given appropriate supports and services so that they can, in fact, manage their addiction. I think there's hope. This region was the first region to step out across America and say, we have a problem. The first region to say, we have a serious issue here with substance use disorder and opioid addiction, and I hope that with folks like you paying attention to this, we're going to be the first region to come out of it. Thank you very much. My opportunity to introduce my colleague and friend, Captain Chris Bersani, Deputy Regional Administrator for the Health Resources and Services Administration. Please join me in welcoming Chris.
Hi everyone, thank you for having us today. It's always good to do a little marketing for the federal government. That's one thing we usually don't get too much money for, is telling people about what we do and what your tax dollars pay for, and how we work collaboratively together, both nationally and on a regional level. So I'm just going to go over with you the slide deck that's in your packet, and I'm going to do it pretty quick. We've got a lot of programs at HRSA, and we've done a lot of work recently in behavioral health, as I'll talk about. coming up here. How many of you are familiar with HRSA? No? Okay. Have worked with HRSA perhaps? HRSA grantee? Okay, maybe half of you. Okay, it stands for the Health Resources Services Administration. It's a mouthful. That's why we've got the acronym from the federal government. So if Catherine represents the Mental Health and Substance Use Agency, HRSA represents the primary care organization within the federal government. So we've been funding federally qualified health centers for over 4 years now. And these health centers were designed originally to provide primary care services to those in need of services, whether you have insurance or you don't, okay? So, let's put the myth aside right now that, there is health care for everyone out there. You walk through the doors of a federally qualified health center, nobody is turned away, regardless of ability to pay. It's been that way for 50 years, okay? Little known secret. So the reason I'm wearing a uniform, I'm also in the Commissioned Corps of the United States Public Health Service. I work for the Surgeon General, and there's about 6,500 of us spread out, sprinkled about throughout HHS, working for different agencies. I'm fortunate enough to work for HRSA. As indicated before, I have a behavioral health background, I'm a psychologist by training, so this has worked out very well for me. I came to HRSA about 10 years ago, and that's really when the tide started turning, where HRSA became much more involved in behavioral health specific activity in our primary health care centers and substance abuse treatment. Okay? So let's just go through these slides quickly so you can get a little bit of an overview of HRSA. The first page here just talks a little about the overview and some of the behavioral health services that we're involved with. I'm going to get into those in a minute here. You flip to the second page there. Some of these HRSA national activities. I talked about our health centers. Currently, we're serving over 24 million people in 1,400 federally funded health centers with over 10,000 healthcare delivery sites. Okay. Over 2,500 here in New England, by the way, and many in New York as well. I want to draw your attention to the last bullet there on the National Health Service Corps. I'm also going to talk about that in a little bit, but that's one of the best little-known secrets, too, about the federal government. That is run by the Bureau of Health Workforce within HRSA, and it is a program that provides both scholarship programs as well as reimbursement for tuition for primary care providers and behavioral health providers in underserved communities. And that has been funded significantly more over the past decade, and there are opportunities for young professionals in that area to receive reimbursement for their healthcare education. So please, anyone who knows somebody who's in the field of behavioral health or primary care right now, looking for some career decisions, include them into the National Health Service Corps. It's a great website, lots of great information in there. It's my plug to the National Health Service Corps. Next slide down talks about health center behavioral health services. Almost 83% of health centers provide mental health services on site, and about 21% provide substance abuse services. I'm going to show you a little bit better graphic of that. If you flip the page, you've got some highlighted numbers there. Again, remember, 10 years ago, that number was very different. And these graphics here show you that. We really are becoming much more actively involved directly in our primary care sites in offering substance abuse treatment as well as behavioral health services. As you can see, there are numbers. But more importantly, down low, you can see where we've come over the last 7 years. In 2008, 2015, our substance abuse services increased 27%. Not nearly enough. Okay, our mental health services increased 120%. So that's where we were, and here's where we are. Now you see, certainly our medical and dental has increased too, just because health center funding continues to be a winner, both with Democratic and Republican White House inhabitants. So we're happy about that. So we think that we have really a very, very excellent program that Congress has continued to feel the need to continue to fund. Flip to the next page, talk about health center behavioral health expansion grants. These are specific grants. So for many years, our health centers have maybe or maybe not, had a behavioral health component to it. More recently, we've really encouraged and provided technical assistance to our health centers to provide integrated behavioral health services. So that's where a behavioral health consultant is embedded in the primary care setting and provides the services, the screening or the behavioral health services right there in the primary care setting, working collaboratively with the primary care team. These are some grants right here that provide some examples of how we've helped our health centers get to that point. The Behavioral Health Integration Services Expansion Grant offered $106 million to about 430 health centers. And then subsequent to that, and in response to the opioid crisis, HRSA reacted by putting together another grant, the Substance Abuse Services Expansion Grant, in 2016 that provided about $100 million for about 270 awardees. So, you know, in some ways we are sort of chasing the dog's tail here, but the resources are there. We are, in my opinion, still behind the 8 ball. We're still trying to catch up on the substance use front. You have to understand that these health centers, this is a whole new business line for them. And as I'm sure you know in your communities, there's a lot of ambivalence about getting into that line of work. And we have to do a better job of letting primary care know that it is not only something that can be very rewarding and helpful, but it really is our duty to supply these services, given what's happening right now with this healthcare crisis. Next slide is about the National Health Service Corps. Again, I want to just emphasize to you, please have a look at this website. It's very informative about some of the opportunities for early career behavioral health and primary care providers. Next couple pages talk about other bureaus within HRSA. I talked about the health center program. That falls under the Bureau of Primary Health Care. There are other bureaus that focus on other populations. The HIV/AIDS Bureau focuses specifically on HIV/AIDS populations, called the Ryan White HIV/AIDS program. And with the HIV population, almost twice as many folks in that population have behavioral health or substance use problems. And so a lot of mental health resources are delivered through the Ryan White program. The next slide down talks about maternal child health. We like to say, don't forget about the babies. This is where the Bureau of Maternal Child Health provides services to mothers and children, just as it says, and families. And one of the new programs the last couple of years that they've developed is a home visiting program, which makes a lot of sense. And I know that you all working in communities, that's an important component that you should know about, because it's a very good resource where evidence-based practices are implemented in the home, including mental health and substance use services. Next page talks about the Office of Rural Health, Office of Rural Health Policy, the Federal Office of Rural Health Policy within HRSA. And the one thing I want to point out on that slide is the Rural Opioid Overdose Reversal Program, which started 2 years ago and is popular and is going to be refunded in 2017. And that is to provide naloxone to emergency responders in rural communities. I know some communities here are working out with opioid overdose programs, and this one has been very popular. We're trying to get it more into the hands of family members who might have somebody who is misusing opioids, so that we can stem the tide even more in terms of overdoses. But right now, it's really in the hands of trained emergency providers in rural populations. Just wanted to address real quickly one of the things that we run into with our health centers in terms of, again, ambivalence with regard to providing behavioral health or substance use services is there has been problems in certain states with same-day billing. So if somebody comes in for a primary care visit, to also bill for a substance use or a mental health problem or a service can be challenging. Just want to, again, take away the myth that there's any federal policy that prohibits that. There is no federal policy that prohibits same-day billing. It is a state issue, and I really encourage providers in our health centers to make sure that they're working with their states, their Medicaid system usually, to make sure that they can overcome that problem of same-day billing. A lot of states have already done that. Some are still stuck. Okay, next slide, I just want to talk about SAMHSA HRSA program that has been going on a few years. This is probably the most important resource on this set of slides. I really encourage you to check out this website. It has really, since 2010, this program has been collecting information and resources on the integration of behavioral health into primary care and effective treatments. All right. I'm getting the high sign here, so I'm going to give you one more slide with a resource, and that's my contact information. So I work in the Office of Regional Operations within HRSA. My office is in Boston. Always happy to hear from folks, so this is my card that I'm giving to all of you. Please feel free to reach out to me if you think there's any collaborative opportunities or questions that you have on any of these programs. I've got 10 years of connections in HRSA, and I can probably get you the right person if I can't answer your question. I thank you again for having us here today, and we're going to open this up for questions for any or all three of us that we can address.
Thanks, Chris.
Yeah, this is a question about money. Do you have more of it?
Go right to it.
Yeah, especially for community health workers. Last time we all met, the first time we met was at Yale, with the help of Dr. Emily Wang, who runs, co-founder of the Transitions Clinic National Network, and intentionally uses a community health worker with an ex-offender background and has showed dramatic decrease in ER use, maybe even recidivism. The only place I know of, Maryland, is the only place that put $10 million into programs funding such folks. Is there any federal money, locally or otherwise, funding what you all know makes a huge difference, getting people within the first 2 weeks of coming out of prison and other such, especially people with substance abuse issues coming out of prison?
It's a very good question. There are some, as the return on investment data and the evidence base has grown with CHWs, the federal government has increased its investment. So there are some dedicated streams of money that go through the AHEX at HRSA, the Area Health Education Centers, that fund training and support salaries for CHWs. There's money that comes from the CDC to support CHWs, and there's money that comes from payers. So Massachusetts has just had its, just as an example, has just had its Medicaid system, a waiver approved by CMS to start using more of its funds upstream to support CHWs. The waiver doesn't prescribe that accountable care organizations must use CHWs, but it's permissive. It says that ACOs can and where appropriate should use CHWs, and that Medicaid money can be used to pay for them to do upstream intervention. So, and there's also some new research money at the NIH around the value of CHWs. So I wouldn't say that in the last year we've seen a huge increase, but over the course of the Affordable Care Act, there have been these additional investments. The thinking of the federal government is really that CHWs will become mainstream and that payers will pay for CHWs, because grant-funded CHW programs are difficult. They go for 2 or 3 years. Even the grants I mentioned in Worcester for the Center for Health Impact, the philanthropy working with CHWs and opioids, that's a 2-year grant. So the idea is to have Medicaid and other payers sustain reimbursement for CHWs as a part of the medical team that Catherine mentioned. Not the medical team, the community health team that's going to work with individuals. So, we can send you some of the links about some of these increased investments, and happy to talk to you afterward about some other philanthropic funding that's available.
And I'll just add that the research does help, because when Congress sees it, there's actually been some research out there that says a particular profession assists in the outcome. The funding tends to follow that, and with the behavioral health integration grant project that I've talked about before, if that does get refunded, HRSA is pushing for community health workers to be part of that.
Jared?
I would just add to that in Massachusetts we have had a federally funded program called Access to Recovery that has provided not community health workers but peer recovery coaches, as well as some other support for people coming out of incarceration. And the state's going to pick up the funding of that, and if you're interested, come to my breakout group, I guess.
Absolutely, and as we said, the notion of CHW supporting peer recovery coaches and leaders is really important. We don't want CHWs to supplant, but to support.
Yes, sir.
Just, Bob, thanks for asking the money question. Just to put into context in terms of the capacity on the ground. So sadly, the public health workforce has contracted over the course of the last 8 or 9 years. To put it into perspective, so over 40,000 jobs have been eviscerated from coast to coast, supporting the infrastructure of local health departments. That's about 22% of the workforce. And by our math, it's going to take at least a generation to rebuild that. So trying to think of different ways to involve other members of the village, recovery coaches, community health workers, whomever it is that we can at least involve in the process. So just keep that in mind. Again, speaking from the community of local health officials, that's why we're looking for better alliances strategically with other partners, irrespective of which level, but just so we can make sure that we have the capacity on the ground. So it's the right question about funding and consistency, but just know that communities are in crisis, and just know that in the aggregate, as one resource, one of many as health departments, we're seeing an erosion of that infrastructure.
And one of the things that comes with that is this sort of maldistribution. And so this whole notion about how we used to build these workforces by doing appropriate recruitment and retention, all of those things are out the window because of the maldistribution now in terms of where people are. And you see the same kind of exodus when states no longer fund the level of capacity of community mental health centers and substance use disorder agencies. That's the same thing that's happening there. And so if we don't recreate sort of a community health response team, then we'll be stuck. And I think you're right. I think it is going to take a generation. And we're also trying to work with other federal departments like the Department of Labor, like VA, like DOD, and looking at how are they gaining people into their system to deliver health care and not robbing the community players, but doing some sort of shared arrangements. And we're trying to think through that. So that's a really good point.
And I just want to pick up on that. HUD and EPA and other federal agencies really appreciate the value of CHWs, and HUD was quicker to come to the value of CHWs even than HHS was about 8 years ago with their funding of CHWs. So there are lots of partners federally and at the local level that can, and that's why it's so important to see law enforcement here, because talk about going upstream and trying to understand sort of the corrections, law enforcement, public health nexus, that's really critical. So our partners, certainly don't have to be in the health sector at all. And the problem will be, of course, that many of these programs are eventually, if you trace the money back, are funded by the federal government. And if the federal government is going to see an across-the-board cut, then we're really going to have to turn to non-federal sources or to payers, commercial and Medicaid payers, to help us fill that gap.
I appreciate you talking about the different areas that opioid has, opioid epidemic has permeated. But as you look to your policies, is there any plan to talk with, or have you started talking with the education department, HUD, and or the CDCs in the different regions about how all of this is affecting and what can we do for in the next couple of years?
Yes, there have been some conversations. Betsy's really the sort of liaison with CDC, and she can talk about that. But we are trying very hard to get the Department of Education, especially at the state level and at the community local level, to talk about where, in fact, are you raising this issue within the educational system, and how early, because of this early age issue of onset, and the whole reality that in an adolescent era, you tend to do a lot more experimentation. There's an openness to doing high-risk behaviors. Education has to be a part of it, and so we do some grant programs in SAMHSA with the Department of Education, which are eligible for schools to apply for. We have a program called Safe Schools, Healthy Students. We have a program, the National Child Traumatic Stress Initiative. All of those are available programs to help bring an education message into different educational environments. We're particularly concerned about community colleges and universities, where suicide continues to increase and anxiety and depression continue to increase for this generation. And so having the right kind of practices and having the right kind of connectivity, having access to those services is hugely important.
But I come from a different, I'm coming from a different level because I sit on an advisory board for the early childhood. And so just looking at the kids that are not yet in school, that have been affected, whether they were born addicted to some kind of substance, cognitive development, all that thing, everything will be changing in a couple of years. It started changing, but the teachers will be seeing it.
Right.
And so are there supports, will there be supports for teachers, one?
Yes.
For parents and for caregivers as we move through
Yes.
with these children that
Yes,
are coming up?
both the Department of Education I would look at, as well as the Administration for Children and Families, which is another federal agency that's bigger than all three of us combined. So the Administration for Children and Families would be a really good federal agency to look and see what they have available in terms of their child. They have a child welfare and TANF and a whole set of programs. And that coupled with the Department of Education is where you're going to find those resources. Okay.
And I just wanted to say, in addition to that, it's a really good question. Elaine Zimmerman is not here. We will bring this back to her. She runs, as Catherine said, the Head Start and all the early childhood pieces that the federal government offers. But I just want to say one thing. The state health officers, your public health officials in all 6 states are working really hard with their state education departments and with localities around that early education piece. So you've got the federal ACF working on 0 to 3, and you've got your state health officials really pushing their education counterparts on the kids in school. And we can talk some more about that during the rest of the day, but it's a very critical point.
I think we're getting a high sign.
Yeah.
We want to thank you all very, very much. We never get flowers.
That's what my wife says. Now she does.
I'm sorry. Can I just say one other thing that we didn't get a chance to say, and I want to say to this group about opioids and substance abuse. When this was a problem in the 70s and 80s, in the post-Vietnam era, when heroin was an issue, it was a criminal justice issue, and the way that this country dealt with it destroyed generations, particularly of African-American families in this nation. And I have people who work on my team whose families were directly affected by that. And I know all of you are people or know people whose families were affected by a criminal justice approach to this. Now that it affects white people in middle-class suburbs, it's a brain disease. Now, partly that's our science has evolved, but partly this was an issue around race and class. So I just want to say that out loud to all of you, and we recognize that in the federal government.
Great way to end this conversation, and so we will be sharing some resources from our keynote presenters, including contact information if they're willing to share that with all of you over email. And we started a little late, so I have to do a little bit of timekeeping. So we're going to do the breakout sessions now. I'm going to make them 50 minutes instead of an hour, so we have a little, we still have time to connect, but and then maybe make lunch a little shorter, and we'll see how that goes. So just as a reminder, so we'll be putting signs on the table. The topics are mental health first aid trainees, safe station, suicide prevention cafes, getting and using real-time data for opioid prevention and opioid overdose prevention, and looking at prevention and systems change from the substance abuse user perspective. So 5 different topics. I think we have about like 8 or so people each topic. Try to spread out. So not everyone from your community goes to the same session, obviously. And we'll be using also some of the tables over on the other end of the room so that we have a little more space. And also speed of note taking.
They had to bring the presenters already.